and it's a Healthy Friday conversation, but this one we're taking on a bit of a policy perspective towards that, to then look at issues around the patient versus the medics, and what exactly are we looking at in terms of numbers, and where exactly do we need to be. There have been of strikes, many. And one of the issues has always been we just don't have enough to go around, and what's going to then be necessary to sort that out. Olivia Koth is the Chief Executive Officer of the Commonwealth College of Medical and Related Studies and joins us in the Situation Room this morning. Good morning, Olivia.
Good morning to you.
Karibu sana.
Asante.
Thank you for being here with us this morning. Seth Panyako is the Secretary General of the Kenya National Union of Nurses and joins us here as well this morning. Good morning.
Good morning.
Karibu.
Thank you.
We're going to get into this conversation to then try and understand exactly where we are. But before we do that, we'd love for you to interpret our proverb, which Dennis will share.
Yes, our proverb comes from Mauritania, Islamic Republic of Mauritania. But before we get to the proverb, some of the few things that they are rich in, phosphate, talk about copper, gold, gypsum, as well as fish, because they are a port country as well. The proverb that we get from them: the rat that follows the scent of roasted meat into the trap cannot blame the cage of wickedness. The rat that follows the scent of roasted meat into the trap cannot blame the cage of wickedness. Ladies, go first. How would you interpret it?
Olivia?
How would you interpret it?
I would interpret it that sometimes when good things seem to be put somewhere, there is always something hidden that could trap you in it. And therefore, we must have a lot of wisdom to know whether we are walking into a trap or a genuine goodness.
SG, how do you interpret it?
The same way, but a little bit different. The same way that you are following those good things, but you know very well that they are not heading the right direction. So you actually have the information already. It's not like you don't know. So it's upon you. You are going, but knowing that in Kenya, in politics, you say, my body is there, but my heart is not there.
Okay.
Yeah.
Interesting. All right. Let's start off with what might seem like an obvious answer or an obvious question. And is there a disparity between patients and medical workers in Kenya at the moment? Olivia?
Yes, there is.
What kind of one?
Because disparity, we are talking about our workforce being able to fully take care of the patients who appear in our facilities. And our facilities are divided into those sponsored by the government and those private-owned or faith-based facilities. The disparity in terms of the labor force which is there and the amount of patients we have to handle every day. And in terms of availability of the equipments that we need for the health scenarios that we have. Yeah.
And what does that look like? There is a disparity, okay, but let's see what it actually looks like on the ground, that we can walk into a medical facility, for example, or look at how things are being handled. How would we then be able to see, touch, feel this disparity? What do we see presented?
When you go to hospitals, you'll find long queues of patients waiting to be attended to. And some of them might even narrate and tell you, we have been here for 2 hours, 3 hours. We've not been attended to. Those are signs of disparities where, for example, in terms of nurses, nurse-patient ratio is extremely low in our public health facilities as well as private health facilities. And that leads to burnout in terms of healthcare workers and lack of individualized patient care. This leads to a slow healing process and even increased mortality rate in our public health facilities and private health facilities. And that's what you will see. Yeah.
You mentioned something very critical there. Mortality rates going high. Delayed response and attendance to patients, among other, impacts of the, coming from the disparity. But rarely do we hear the disparity captured as one of the components of when you see research and reports, right? When you're looking at child mortality or otherwise, rarely do you see disparity being cited, that there were not enough attendants, if I may generally call them so, and therefore this caused this prevalence of a condition or mortality. How is that so that this is never captured in the research and the reports, or have you seen it in yourself?
It is properly, it's captured actually, because when they talk of high mortality rate, and the ministry itself comes up with numbers to show that these are the numbers we have, and the numbers we need. It means they appreciate the level of shortage that we have in the country. The question will be, what effort are being made to ensure that the gap is reduced and we have health worker to patient ratio improved, so that health outcome can improve. I can give you an example. I think it's Mandera. Before devolution, these are some of good results we can say have come up in some areas, but they're isolated cases. We used to have very high maternal mortality rate in Mandera, but after devolution, there was increased staffing in that area, and there was increased facilities, like they did their first C-section after devolution. We have had zero maternal mortality rate, death in the mortality rate we have zero mothers dying the last financial year when it was evaluated. And
in that county?
In Mandera. And that's something very good that we should be proud of, because myself, I am someone who is very much touched with the maternal child health. I keep saying that my sister when she was giving birth, and that made me feel like I need to do more in maternal child health, because she lost her life and her child also passed on. And therefore, it made me attached to the mothers. You know, if there's any war that's ever been fought on this earth that has never been recorded, is the war of giving birth. Mothers go through a lot, and therefore, we need to look at those numbers and act on them, both private sector and public sector. Because when you talk of, for example, I'm a nurse, I more talk about nurses than opposed talking the general healthcare workers. The nurse ratio in Africa and the Eastern Mediterranean countries is very low. You get of like 1.5 nurses to about 1,000 population, and that gives you about three nurses per 10,000 people, while it's required on the minimum to have about 25 nurses to 10,000 people. The highest in those developed countries, we say the well-paying countries, they have about 40. And between 35 to 40 nurses per 10,000 population. You find that in America, Britain, and they still cry of shortage.
And here you said the number is?
It's three.
Three
nurses per 40. Per 10,000 people.
Okay.
So it is like 1 to 3,500 thereabout.
You see, while in the Western countries, it's about 9 to 10 per 1,000. That gives you about 35 to 40 in a population. And Africa and the Eastern Mediterranean, we're supposed to be talking about the minimum, which is 25. We are doing 3. So you can imagine if you might have heard stories, but if you have gone to public health facilities, you will prove that at some point in Busia, I think it has improved. We had one nurse managing 3 wards. You ask yourself, what is she doing?
I mean, Olivia, if we talk about the number of nurses, then we have to equally go back and look at institutions that put them there. You go to KMTC and other medical colleges that do exist that churn these medical professionals into the system. How many are we graduating, and are we seeing equal measure in terms of absorption into the industry? Is it that we have not graduated enough professionals to meet the numbers that we have, or is the problem absorption within government?
When you talk about training and training to skill the healthcare sector, you don't. I wouldn't talk only about nurses. Although nurses are the custodians of the hospital, and we also can't run without them. There are so many cadres in the hospital. In different sections that generally as training institutions we produce a lot of graduates, but the absorption after internship, let me say so, after a student has fully trained, has been to internship, then they stay home for quite some time, and the health sector, as we say, is understaffed, but still then there are people to be employed. So at the end of the day, there is no match between churning out and absorption. So what I would say is that training institutions are doing their best to train to standard the health force that we require, but then our trained personnel remain out there without being able to be absorbed to assist the country well in terms of treatment.
Why aren't they absorbed?
Policy.
What?
Of course, you know they are not absorbed because there is no job which is advertised. So,
No, I don't know. I'm asking why. Why?
Are they not absorbed? Yeah.
Why do we have training facilities churning out medical workers, whether they are doctors, nurses, radiologists,
Clinical
officers, nurses, and then they're not absorbed? They're being trained because I would assume that they're being trained. I'm assuming that we're doing all of these things based on data and information. So they are being trained because at the end of that training, there is a need,
Yes,
right? And then there are people who then can get the skills to then be able to do this job. So why then at the end of the tunnel is the absorption not happening?
There is a process of human resource acquisition, be it in the government sector or the private sector. The need has to be announced that now we need this. And then we have to say we are ready.
The need
But
has
you see,
been
the
announced.
need-
It is shouting.
No,
The need is shouting.
No, that's not
sorry,
the need.
Olivia. Come on.
It's
Come on.
shouting, yes.
That we have been told that the disparity is there. What that number is baffling. I've even forgotten it.
Yeah, I think
3 to 10,000 to 100,000.
To
3 to-
100,000.
Okay, let me not
10,000,
say
yeah.
the need. Let me not say the need. The need is there, but the decision to address the need is what is not there.
Now we're talking.
Let me put it,
Yeah. Okay.
Olivia, let me put it
Why?
differently for you. As we answer the why question.
Yeah.
Because clearly, we have training institutions, right? Which are up to standard. So the people they train and graduate are competent
Yes.
to be our nurses and other cadres
Yes.
of service in the healthcare ecosystem. So we have a production line. We have consumers because we have institutions that are required to fill these positions for them to efficiently deliver the healthcare service to Kenyans. So we have consumers and we have market because the facilities are the market where these services are absorbed. The consumers are the patients. We have money because every project needs resources, right? From our taxes where we see budgetary allocation. Like now we have 177.8 billion allocated to health. A portion should go to part of this recruitment. The question is why, simply, are we not seeing this qualified, competent, certified person who is being demanded by the chairman to be deployed and the resources are being provided? Why are they not working today?
Let me answer that.
Yes.
You see, you are saying Kenyan taxes and you are even saying how much has been allocated to health.
Right.
But in health, there are so many other issues to be tackled apart from human labor or workforce. And then it is about prioritization of the need. Yeah, the need is there, but then we need to do this allocation in a manner that every sector will be covered. But then now, when we are deciding, is when we decide now, this time we are going to get this amount of labor based on the allocation we have. And as Seth will also tell you that the allocation is not enough.
So the issue is money.
The issue is that the money is not enough.
Okay, let me frame
It's
it differently.
inadequate.
Every day or every year, we have the pass out with the police, the army, the NYS. I have never in my days as a Kenyan heard of a policeman who was graduated and they were not deployed. So please help me understand. Seth, help me understand this disparity.
First, the difference between the police, the army, the security agencies, the government one, public one, is that you are recruited as an employee, and part of training is employment. So, as opposed to these other Kenyans, when you are going to college, you go to a private college. And you train either privately or partly sponsored by the government, and when you finish, you scramble for the few available spaces based on the finances that are available. But for the security, they purposely budget for them. But for health sector, there is nobody who's purposely budgeting for the human resource.
And yet,
yet,
both of these have the distinct duty to secure life.
Correct. And you see, during Ebola, they said the greatest army was the health workers, led by the nurses. But you see now, when priorities when politics supersede priorities, and then you see somebody wants to do visible projects that can be seen by the people so that those people can be re-elected. And that's why we said, when you look at the Abuja Declaration of 2000, it said that every state that appended its signature to that Abuja Declaration was supposed to allocate 15% of the national budget, 12. Now in Kenya, how do you do that? You have a fragmented system of government where health has been disbanded and taken to the county governments. About now 48 plus employers.
It's been disbanded and taken to the county government. However, the control of the purse still remains at the national government for health. So it's almost a quasi-devolution of health, whereby they say the function of health, you counties, you may have it. But the control in terms of the money, we are going to keep it here centrally. Can that really work? Because if we're going to be having an honest conversation, let's talk about it as it really is. That the people have been, medical professionals for the last 20 years, yourself involved, Seth, included, have asked about a health service commission. The thing that we are comparing now police to, guess what? They have a commission. And that's why you're able to see certain things happen.
Correct.
Health does not have one. And yet, we have talked about the fact that if you have a sick nation, you might as well not be doing anything. Go to the forest, right? And these are some of the things that we're talking about. So can we have an honest conversation about what really needs to happen? Because we can be talking about the fact that the money is not there. We can talk about the fact that there are hundreds of thousands of people who are being cared for by a very few. Because the thing we talk about nurses, when they're just a few, you can apply the same to doctors. You can apply it to clinical officers. You can apply it to all these equipment handlers across board. Can't we? That's why when you go to referral hospital today, you have lines of people as though they were waiting to get bread. That's why. Can we not talk about that?
I would not say disbanded.
Okay, maybe Seth used
devolved. We can go with devolved.
Health was devolved as per the constitution, but there was no proper plan of the process of devolving it.
So it failed.
Yes, because now, if each county is going to pay its workers when it has the money, so there is a lot of challenges at the county level, and that's where what you are talking about as a commission comes out, that there needs to be a centralized way in which, even if it is devolved, the pay, like if I'm a teacher, just not 25th, I'll be paid
without question.
Yes, but then in the health sector, it changes from county to county, and sometimes there's a hardship in the county, and they're told it's next week, it's the other one, or it wasn't paid. So I think the need to motivate the human resource through a one system of payment and a sure way of sustainability should be discussed. We have seen in the government where they have really struggled. Actually, the government has tried to provide more facilities and even more equipment. But the question of the human resource still remains something that has not been fully addressed.
I have a question, Olivia, after Dennis.
We talk about human resource and availability of jobs. I reckon if you just use the statistics that we do have in terms of the numbers of clinical, health workers that we need vis-a-vis the population, that itself is a job opening, because it speaks to the unavailability of requisite numbers of health professionals that are needed in our hospitals to offer that service. One then proceeds further to ask the question where it is devolved, but funds have not followed the function. Is there political goodwill to address health concerns in the country, especially when you talk about human resource?
You see, the goodwill might be there, but government structure might hinder the goodwill. For example, you have seen the universal health coverage staff. National government in her own wisdom realized that there's great shortage at the county government's level, and they were not willing to apportion money to hire. So during COVID-19, the government decided to do support to the counties by employing these about 8,700 healthcare workers. When it comes to now transiting them to contract to permanent and pensionable, it has been a very serious issue. We have worked so hard to ensure that money is allocated. The current CS for Health, Eden Dwale, has done a very wonderful job, because when he came in the ministry, we worked closely with him to ensure that 8.6 billion was allocated for these people to be put on permanent pension. But as we're talking today, money has been allocated. These health workers have not been given letters of permanent and pensionable. Honorable Eden Dwale has proceeded to change their pay slip to read permanent and pensionable, yet they don't have letters. So there's no goodwill.
Is that constitutional for him to do?
I don't know whether it's constitutional or not.
Okay, it's not.
It is not
illegal.
It is illegal. It's an illegality.
Well, as a worker, as a leader of the worker, what is benefit my worker, I don't care whether it's legal. That's where we say the end charge.
But you should.
You should.
Oh, come on.
When it comes to my member benefiting, the end will justify the means.
But you know what happens? I'm sorry that we have to hold on to that point.
All right.
What happens is that you now put somebody in a state whereby, okay, they're receiving the money and that's great, but then in the future, if somebody comes in that's not Eden Dwale or Seth Panyako, what happens to that documented? So how are we going to continue? What do you do to development? You cut it short.
I clearly agree with you.
Yeah.
And that is why we're on strike. It's one of the main reasons why we're on strike, because they have to transit to permanent and pensionable for them to have security of job, so that even when they are working, they are sure that they'll get salary at the end of the month, and they are assured if they don't make mistakes in the line of duty, they will retire at the age of 60. They can plan for their life. And then they are assured that when they retire, they have a proper pension scheme to keep them going in retirement. That's what we are fighting for. Now they have a pension scheme. They have now medical cover. And to me, that's very good. Now, I'm saying this because there's another example I want to give.
Okay.
Where maybe legislation is not working with the executive.
Okay.
We were promised hiring of 5,000 nurses in this financial year, only to realize that the money was not allocated. So advertisement have not been made. And again, it's being done by the national government on realization that the county governments are not hiring enough to keep to the pace of the nursing shortage, so that they meet the universal health coverage, because human resources is key. And so when I spoke to the minister, he said they are going to have it done in supplementary budget. Yet, this proposal to hire 5,000 nurses was there. So the person who is in charge of the Commission of Revenue Allocation and the Parliament should have looked in this issue and allocated money. But if we had the Health Service Commission centrally placed to look at the human resource aspect of healthcare workers, this will be done, because that will be their work. The way the Teacher Service Commission ensures that money is allocated for promotion, money is allocated for hiring new teachers, and that's why teachers have been hired more than even the police, more than the army. It is only in the teachers where they have hired more than 100,000 workers, where they hired more than 100,000 in 1 year. It has never happened in Kenya. And therefore, we centrally managing healthcare workers is very important. But I want to say, in terms of welfare for the workers, we will not talk about health workers alone, because we don't work alone. There are other departments that make sure that the health system functions. County government have issues payment of salaries. Some of the counties have not even paid salaries for 3 months up to now. And my thinking will be like, we ring-fence the issue of salaries, so that we have, from this salary can be deducted from the source and goes direct to the workers. They deduct money for bank loans, they don't remit. They deduct money for pension, they don't remit. They deduct money for union dues, they don't remit. So you realize that if this is done at the source, we have gone on strikes after. By the way, health is not a devolved function. It's a shared function. I think this is a mistake that people are making. And the moment you continue making this mistake, you know who you are shielding? I come to you. And you say the money has not followed the function. Because you have made this thing called health as a devolved function to be the plain truth when it's a lie. Health is a shared function. And in a shared function, there's responsibility of ensuring that that function continues to operate optimally, remains with the national government. And therefore, health being a shared function. And that is why national government, knowing that it's a shared function and the responsibility remains with them, that's why they hired UHC staff. That's why they want to hire 5,000 nurses.
To fill
they
the gap.
know it.
To fill the gap that they should be filling by hiring people.
So please, let us not talk about health as a devolved function. We have devolved functions like agriculture that are 100% went to the counties. Water. But when it comes to health, we have the national referral health facilities with the national government.
But Seth,
health policy with the national government.
Allow us to take a break. Can you hold on to that question? After
the break.
We're continuing our Healthy Friday conversation, and Joe Kamanya's hot and burning question.
Oh, yeah. Yes. Seth, you didn't just attempt a constitutional coup there when you say that health is a shared function, because it is not a shared function. It is actually a devolved function. And Schedule 4 of the Constitution describes that clearly. So, and earlier on you said you really don't care so long as your workers benefit, whether it is constitutional, what the CS Health has done or not, cementing them as PNP, yet in actuality they are not in terms of remuneration. So, this begs for the question then, is the problem the people we have? Because, even Olivia says the issue is resources, but if police are allocated enough resources for training, recruitment and deployment, the same can be based in terms of data and research and numbers, so that we're able to drive things constitutionally. Is the issue the laws we have, that health is a devolved function, or is the problem the people we have in charge who choose and cherry pick when to suspend the Constitution and when to apply it as they deem it fit?
I think the problem we have is prioritization of the
by the
resources
people.
Yes.
Because the law is clear.
Yeah, the prioritization. Mm-hmm. And also, in a bit, the way we interpret the Constitution and implement the systems. Because law can be there, but how we implement and how we respond to the need is important. So I just believe we have not gotten structures in Kenya that work for us in terms of how it was devolved in the statement of the Constitution, but vis-a-vis how it ought to be. So the proper channel that gives us the best service in healthcare has not been found, because you can't talk of service when the workers are always not paid.
They are on strike.
Yeah. So I think we just need to get the best structure. And where there is usually conflict, or where we see that we are not able to correctly interpret or implement the law, then it calls for people to come and say, we have an issue here, and maybe let's appoint a task force to do some inquiry and find out how best are we able to manage our health system, because as it is, we cannot even run away from the truth. It's not working.
Okay, but why is it so difficult to just follow what it says? Very simply, follow what it says. Because then what happens is number one, we don't follow what it says. Then people get frustrated and they decide to go on strike. Then you know what you do? You come in and they say, okay, fine, you know what we'll do? Let's institute a CBA. You have CBAs that run for 4 years, and then at the end of one CBA, you come and you institute another CBA, as opposed to just doing what the law says you should do. There's a service, it's delivered, you compensate or you remunerate. That's it. But we want to complicate things and we say, okay, you know what? You guys wanted medical cover. Okay. You guys wanted paternity leave. Okay. You also want to actually be paid on time. Let's have a CBA. Come on. That's exactly what we're saying. Let's have a CBA. And then at the end of that CBA, you know what? 40% of that CBA we didn't do. Then we send them to the streets. That's exactly what's going on, because we just don't want to do the right thing. But then now we're saying, so because we don't want to do the right thing, let's institute a CBA. Let's institute a task force to go and figure out how we should actually come back from doing the thing that we're supposed to do. Then we are running round and round in circles, and somebody suffers. Why is it so difficult, Seth?
There's no single country in the world that has done what you're saying, my friend. It cannot happen. Workers must always fight for their rights, even in the most developed countries, even in America.
You must understand that I'm tinging this with sarcasm, because
Yes.
what I'm saying is exactly what's happening in Kenya.
I agree with you.
People are not doing what they're supposed to do,
that
then you
cannot-
enter into a CBA.
We go back to the basics. You remember I said that in Abuja Declaration, 15% of national budget is supposed to go to health. Now, how much goes to the county governments? It's 15%. So if county governments must give optimum health care and meet the minimum, you'll say the minimum healthcare services that is okay for the population, it means the entire 15% they are getting should go to health, which is not practical. So that's why we're saying if health is centralized and human resources managed, you can be, now we will not be fighting about just roughly employ more nurses, do what we'll be saying, allocate at least, maybe if you're doing 4%, we say, can we allocate 8 this year? So when you allocate that 8%, then we come and say, out of this 8%, how many more health workers are you going to employ? But today as we talk, every county is doing what they have to do. And practically speaking, maybe in the past people were not keen about health because the last hiring that took place with the national government before transfer, not devolution, before transfer of functions. You know, I'm very keen with the language I use. There's nothing like devolving a function. There is something like transferring a function. Before the transfer of health as a function, part of the health as a function of the county government had just hired 300 nurses for the entire republic. So if maybe, I'm saying maybe, the county governments are given enough resources, they can do better than what the initial county government did, national government did. Because a governor like, I keep referring to Honorable Mutua because he did something that nobody else has done. He was the only governor that hired 800 nurses at a go. He found a population of 400 nurses in Machakos. He hired 800 on the spot, and they went to 1,200. And they have tried to maintain that population of 1,200 nurses in Machakos up to now.
So it is possible.
It's very much possible. Very much possible.
Why is it not happening in the other 46 counties?
No priorities.
By who? Who is this that is relegating what you're identifying as a key priority for the national health system? Because remember, as you rightly put it, the person who suffers is not just the nurse who is not employed. It is also the patient who does not get the services on time. The child mortality we are talking about, we are saying we could have saved a life of a child, an infant, at birth, if only a health care provider was present. So if you look at it from that macro perspective, we must answer this question, if not today, but very soon.
I think
who is this that is relegated?
I think she are responsible for this health.
She already answered that.
About. And you see, we have 48 of them.
Right.
And he's talking of only 1 out of 48. It means bringing these people together to make common decisions that is going to further the healthcare sector is important. And the question is, who is going to do it?
Okay.
To make every governor realize that health is a priority and to allocate adequate resource to it in terms of human resource and in terms of equipping and all that.
48 county governments.
No, we have 47 county governments.
Plus the national.
Plus the national 48, plus the state corporations, more than 50 employers within public
more
sector.
than 50 employers within the public sector,
Yes.
right? And that right there is confusion. There has been talk on having the National Healthcare Commission, right? And that would then harmonize the structures that then gets to handle the health workers within Kenya. What is stopping that process? What's delaying that process?
You know, when the constitutional making process was taking place, health sector did not have a single union.
Yes.
Those that existed had other priorities, and professional associations had other priorities. When teachers were fighting in Naivasha that Teacher Service Commission should not be removed, our colleagues, the healthcare professional associations, were fighting about apportions. They did not understand the need to have the Health Service Commission. It will require a referendum for us to have the Health Service Commission. Even if you try to bring other bodies to advisory, whatever, let Kenyans fail us, then we tell the Kenyans now, don't complain about poor health services.
And Seth, as we just piggyback on that, then, if you talk about healthcare, you talk about Wananchi. Wananchi are so concerned about healthcare as we speak right now. And when you talk about referendum, it is them who will go to cast their vote to either pass that commission or not, right? And knowing very well that Wananchi is at the center of this conversation, are we pushing it?
No, the challenge
to
that
them
we have,
to understand the importance of this referendum being a question even as you approach 2027.
The challenge that we have is not a common Wananchi. This constitution, we gave powers to the people as provided in Article 1.
Yes.
But inside the constitution, we took away power from the Kenyans. For example, when you collect 1 million signatures, just a few council, MCS, will sit and they'll be bribed 10,000 shillings each, and they'll fail that referendum. If it fails at that level, it will not step in parliament. So that thing of saying collect signatures, take to the MCAs who can be bribed by 10,000 shillings, and then they bring that motion down, is the greatest mistake. We took away the powers from the people. It should have been, if the MCAs reject, it still goes to parliament. And let the people decide. Once you have, even the threshold of collecting signatures should have been high. But the people overall Kenyans must make it. You can imagine 1 million signatures being brought down by about 2,000 people. So we took away the powers from the people. The people have no powers. Even if you want to amend that constitution today, and somebody will go and bribe 24 county assemblies, it will not see the light of the day. It will die there.
I am sticking with this like a dog with a bone. We have a National Human Rights Commission. It does not stop the violation of human rights in Kenya. So even if you formed a commission basically for nurses, right?
Not nurses.
Medical.
For healthcare workers. For health workers.
For health workers.
Yeah.
According to me, I do not see how that will improve the disparity. I do not see how that will improve the quality of service provision at the all health facilities.
I'll give you an example.
Look at what it's doing for police and teachers.
Correct. Yes. Even the police, the teachers, even the what else? Who else? These all workers that have a commission in Kenya, they have their priorities right in the budget. For us, the budget will go to the counties and 15%. And this staff shortage, let us not forget that the national referral facilities has acute shortage. Go to Mathare. Mathare is supposed to have about 1,500 nurses. They only have 270. You can see that level of shortage. So, and even that Mathare National Hospital is supposed to move to Ngong. It has not moved. Why? Some fellows want to eat the money. So you can see that when we talk about this problem, we should not look at the county government alone. Even national government has problems. The national government is better today because it has the correct CS. If that CS left, as you have said, and another one comes in,
you said the correct CS.
Yes, the right person. You know, we have a CS who does things, who moves things. You discuss with him right away, and he will pick a phone call, and will call the person
because he did move.
But you will have another one.
Yes. Just so that we are on the same wavelength with fellow Kenyans. It is true he moves things because he also moved 11 billion Kenya shillings, but we don't know where it went.
That should be a discussion of another day because I am not. We are clearly talking about disparities today and the problems about it.
Right.
For me as a leader of the workers, I will look at what affects me and affect my members. Of course, that 11 billion will affect us because the hospitals will not have the medicines, and that's what is happening. And there are people. That's the National Commission for Human Rights, isn't it? You said there are also other bodies established within the government to ensure that such 11 billion does not move. So if they are not doing their work, I'm not going to do their work. My work is to defend nurses, and that's exactly what I want to do and do it perfectly, so that when I retire and go home, I can be remembered for defending the nurses.
Do you reckon that the country is having honest conversations, especially when it comes to healthcare? Because fine, we say it is devolved, but money remains with the national government. Statistics shows that we have less nurses. We shun out enough nurses that would would address the issues that we have, but you don't want to institute them. We know where the issue is. We want a health commission, but you're not having this conversation. As a country, are we having this conversation about healthcare with total honesty on what solutions need to be given?
Currently, as it is, we are assuming, I think as a country, we are assuming that our structures are working. But by the outcome, you see, for everything you do, you must evaluate, and evaluation comes through the outcomes of something. Now, if as a country we had, as Seth is putting it, partly devolved some services to counties and retained some services at the national level. But then the I would say specifically the human resource one is not working at the county. And honestly, we need first we need a political goodwill. Yeah, because as Seth is saying, bribing or whatever, those are political aspects of it, which if there is political goodwill, I think everything can work. So first of all, we need political goodwill, and then secondly, we need to honestly have a discussion about health in our country.
Well, and I couldn't agree with you more. But while at it still, when you look even at the national facilities that get direct budgetary allocation, pick Kenyatta, pick Moi, they are not doing any better. So even, and you see, that would have been a point of reference where we say these national facilities, they are well managed because the utilization of resources and human resource allocation is appropriate or adequate as per the times, then we can use that as a benchmark and say perhaps indeed we need to revert to not devolving the health care function.
That's the more reason why I've said we
Yes.
need to have a honest discussion.
Right.
Because first of all, even what is under the national government is still inadequate.
Right.
Probably the only thing they ride on is that they're paid on time. But still the number is inadequate.
Low. Yeah.
So that it means that we are, as a country, we need to reassess.
That paying on time is not something you can take for granted.
Yeah.
When you look at almost 60% of our industrial actions emanates from non-payment of salaries.
Really?
Yeah, so 60% of our industrial actions. After devolution, it's the first time health workers went on strike for non-payment of salaries.
Non-payment of salaries, and
In
not
nation-
not just late payment, but non-payment.
Non-payment.
Okay.
If you stay for 3 months without payment, we have like employees in Kajiado here. They were hired in January. They have not earned salary up to now.
It's
How do you expect them to be surviving?
That's a
that
good
never
question.
happens in national government. And you expect them to be reporting on duty. And that is why we're saying the Health Service Commission is not a national body, nor a receipt account body.
Yeah.
Because we expect it to have representatives from the county governments and the national government. And her responsibility of that body will be strictly to do the health human resource policy, looking for funds, both from the budget allocation and even looking for funds to ensure that health runs in this country. We have a good example. I keep saying myTuner Referral Hospital has been a good example for many years. When Dr. Raza was the CEO, and you see when he left, we had some changes. And we started going back to the issue of non-remittance of statutory deductions, what and what. And of course, there is something that was introduced in a public health sector called e-system, the e-citizen. You know, that thing takes all the money from all our public health facilities. No one wants to talk about it.
Yeah.
When that money rarely comes back. And that's why our problems, even in Kenyatta National Hospital, let us not fear saying the truth. Kenyatta National Hospital is having problems with medication. There is no medicine in the hospital, not because the money is not being, because money for buying medicine comes from the patients.
yes.
Not because money is not there, but money is being centrally collected. With that money cause, it's not coming back. The same applies to myTuner Referral Hospital. And if this does not change, we are bound to continue to have this shortage of medicines at a very high level compared to what it used to be in the past.
Well, we could talk about problems until the cows come home. But until we start thinking of how to formulate solutions, nothing is going to change. Clearly, there is no clear path to a possible foreseeable solution because we keep, shifting the goalpost.
Oh, some of them are very easy, my friend. Just change the e-citizen. Let the money be spent at the source so that medicine can be bought. The way it used to be.
Yeah, but you there is an underlying note that there is political interference.
Correct.
so it's not as easy as we are putting it, but clearly we can see the problem. But let me ask you, Seth, if today Olivia and I had the powers to make you the CS of health, are there things you would do differently at the policy level? It doesn't have to be you as a person, but I'm saying if we had the right person who understands the mandate of the healthcare ecosystem first, and the mandate they have as the person in charge of the health system in Kenya, the healthcare ecosystem in Kenya, perhaps things would change. Are there things you do differently?
You see, doing things differently depends on what we have all been talking about, the structure and the systems of governance. You see, it will depend on how I relate to the appointing authority. The current CSS we have, unfortunately, you can't compare them with the ministers we used to have. These are people who have no powers. So it depends on the kind of CS, and that's why I'm saying Honorable Eden Twaleka from the political success. He was not a political failure. He was plucked from his seat as a senator and was made
As a member of parliament.
So when he speaks maybe to the president, there's that level of respect of each other and friendship. And maybe the president listens to him. But if I'm the president and I pick you from somewhere I think you are suffering and I make you a CS, you won't even face me and address the issues affecting my ministry. So it's not easy for the current arrangement. Africa is not ready for CSS. We picked the American system and brought it in Kenya. And that is the problem that we have.
Olivia doesn't
we need
agree.
ministers.
Olivia doesn't
We need
agree with
ministers. We need ministers who have been elected by the people as members of parliament, and then they have been given added responsibility as ministers. So that if I face the president and say, this is good for the country, and the president refuses, I tell the president, take your ministerial position. Let me continue being a member of
Olivia
parliament.
doesn't agree.
But
with
today, if you do that as
Yeah.
a CS, you'll be fired.
Olivia.
Yes. Olivia.
I don't think Kenya has a wrong system.
We have a wrong
I
system.
think we just need to listen to each other. Because what you are saying that I have to be a politician to address a president is not true.
Right.
Yeah.
I'm telling you, you must have some backing. You must have some force within yourself for you to execute the mandate of that office. But when I'm electing you as my secretary, it's called cabinet secretary. We were not stupid when he said cabinet secretaries. Why did we move from the minister to cabinet secretaries? Who is a secretary in your office?
Could this be?
You see that?
You see, the bigger question here is, the cabinet secretaries in office are there and given that mandate by the people of Kenya.
They're not.
No,
Right?
they are
Currently are not.
No, they're appointed by the president.
Appointed by the president.
Allah?
To serve Kenyans.
To serve Kenyans.
To serve
And
Kenyans,
that
to
means
work under the
at the
executive.
point where you as a cabinet secretary know very well your mandate is to deliver to the people of Kenya, but political undertones is stopping you from doing that.
Correct.
But if we're
Resign.
being honest here, when we talk about appointments of cabinet secretaries, they're made by the president
Yes.
and most often look like awards.
Yes. And you can be fired anytime.
So, Olivia, could this be what you're saying?
Issue is not how we appoint people, is the people we put there are people who do not have interest of one and shared
Let me
heart.
ask you a question.
Ask.
No. You see, we had Nahumecha in the Ministry of Health. We had Barras in the Ministry of Health.
Yes.
They failed to give us 8.6 billion for UHC staff. They failed to give us 7.6 billion for interns, health workers. Honorable Duale came and within 3 weeks, we had money for interns and we had money for UHC staff now. So what is the difference? It's not the same ministry. Were they not asking? Communication was there. I was here, I remember, and I said all communication has been made.
The common denominator here is the president, right? Who is
course
the
he is.
appointing
Of course he is
authority.
appointing
So
authority.
when his juniors fail, the president equally has failed.
It depends also on how you approach the president. If you are not able to convince the president that this is supposed to be done,
That's the problem. Why should you need to convince the president about
He
something
knows
that's
his role.
constitutionally
that is the
bound?
system you put
He
there.
knows his role.
That is the system you put there.
Said
Anyway,
our system
yes,
is the
Olivia.
constitution.
We cannot run away from the fact that
Yes.
even if you are the manager of a place, a president manages Kenya.
Right.
The how issues are presented to you would make you make certain decisions. And to that extent, you might be right. We are also not absolutely right saying that CSS are not, they don't have the capacity. Because most of these CSS are also appointed on political recommendations. So I would just say that I would just say that people have different ways of doing things, and in this case, if you are giving CS Duale some credit, I think he just has his way of doing things.
Okay.
Because even in politics, we have those who excel tremendously, and we have those who are
fail.
Now,
all right.
I'll put it to you as we wrap it up that I think the problem we have is now this kind of different school of thoughts, where you have different personnel, different people, different beliefs, suspending the constitution, the one binding document that should guide us on how to protect the health and the welfare of all Kenyans. Perhaps if only reverted to that document called the constitution, regardless of our political allegiance, we might have a working health ecosystem.
And one would also argue that even as we close out this conversation, that if you take the constitution and put it where it's supposed to be, it wouldn't matter who, it wouldn't matter how, that if you followed the constitution as a guiding light, then you would say, okay, fine, this is how we're supposed to operate, and everybody else just plugs in. Olivia Okoth is the Chief Executive Officer of the Commonwealth College of Medical and Related Studies. Seth Panyako is the Secretary General of the Kenya National Union of Nurses. Thank you for this Healthy Friday conversation. It is clear from this conversation that there's a lot of work to be done, and we cannot stop engaging.
Situation Room, the only way to start your day.